I have the pleasure of doing the next talk. So I've just actually added my questions in the first slide itself. So I'm moving on. I have no financial disclosures. So my questions are: which laser, how confident to make the laser, where to do the laser, and who will monitor? Is it a single session versus multiple sessions? Posterior to ridge, when and what are the indications? And laser after anti-VEGF. So it is still the gold standard. Anti-VEGF is coming up, but that's another talk. I just want to bring the, I have no financial disclosures here, but Tropac P Semi is back into the market. And for those who are interested, that's the phone number of the company, because the AuroPen Plus was taken off the market. Which laser? Well, Dr. Dogra's group has shown many years ago that the green performs so much better than the diode. And I think, all of you who are doing adult retina as well, that laser can be used for your diabetic retinopathy patients as well. So the green laser is the way to go forward. Pre-treatment, Madam mentioned the anemia and the thrombocytopenia. Analgesia is something that's important. Almost all of us are trained to do treatment under topical anesthesia. So what we do use is, of course, topical anesthesia in the form of proparacaine, but we also use these sugar pellets. So sucrose was what was mentioned in literature, but 5 to 10% dextrose just does the trick. One important trick to make the baby comfortable, warm, prevent hypothermia, and you comfortable to prevent movement of the baby is the correct way of swaddling the baby. So always use linen, don't use synthetic cloth because it stretches and also the sweat absorption is not as good. Separate the two hands. If both the hands are in one fold, then the baby tends to be more feisty and moves off the folds. And of course, in our setting, we keep 1 foot out, and that is to plug the pulse oximeter. But the majority of their surface area is in the face, and you don't want to be exposing that. Also, the drops that you keep putting onto the cornea during the laser to keep it moist, a lot of it falls on the side and makes the cloth wet. And that itself can be a risk factor for hypothermia. So make sure that it is dabbed and this whole area remains dry. What is the correct position to place this baby to do the treatment? Well, any surface, as you can see, this is me trying to do it on the top of the RecCam shuttle. Of course, this is not always advised, but the correct position for your ergonomic best setting would be about a palm length below your umbilicus, and that's where the nose of the supine baby should lie. How many spots? Often we are asked, and I don't think you should be counting the number of spots as long as all the avascular retina is taken care of. A rough thumb rule would be about 2,500 spots or less for anything that's not APROP. We've gone up to 4,500, 5,000 spots and even more. But again, don't count. And as this montage shows you, you want to be about half a burn width or almost confluent. So when you're about half a burn width apart and you have this very smooth contoured laser posterior border, then they heal very well rather than having a very jagged edge of the way you would treat. And when this heals, it heals with a syncytial scar. So the scar doesn't have any gaps. All the avascular area is taken care of. As soon as you see tunica vasculosa lentis, it's not an indication for anti-VEGF, although that is one of the indications. If you just massage the eye as you go around trying to examine 360 degree, more often than not, it will dilate. And despite this angry looking TVL, you would be able to look through the pupil and actually complete the laser. Now, what happens in incubator-dependent babies, as Dr. Dogra's group has shown several years back again, that if you have a sloping wall, you can actually put your hands into it and treat this baby quite successfully. So again, this is a good caveat for your neonatologist. When you can treat a baby through the incubator wall, why can't you screen these babies? So don't wait for a baby to get healthy. It's the sickest babies who have the worst disease. So screen on time and tell this to your neonatologist friend. Now, chemosis, sometimes, especially babies with anasarca, low protein, they'll have chemosis even when your manipulation is very minimal. And this can sometimes preclude the view of the retina if it falls on the limbus and on the cornea. So you have to be just patient and move around this chemosis, as you can see in the picture, and then you'll be able to complete that. Almost always aim to complete the entire laser in one session. The exceptions are possibly in APROP. So when in APROP, when you're addressing the flat neovascularization, then you can either treat on the NVE, and I'll show you that in a picture shortly, or treat up till the NVE, wait for the NVE to retract, and then go ahead and laser on the ischemic retracted edge about a week or 10 days later. So if you can see this, these are the laser marks that are about a week old, and this boat-shaped NVE has now moved posteriorly towards the macula, exposing this ischemic area where the NVE was sitting. So if you go back and laser on the NVE now and that ischemic retina, then you get the best outcome. You will get no lingering ischemia, and you won't have any fibrosis as well. My next few slides are all going to be cases. I'm going to move them fast. My preference for even a zone 1 ROP, if the fovea is vascularized, and we do here a lot of angiogram on the REDCam 3, is still laser. Of course, this was way back, this about many years ago. Sometimes these cases do much better with anti-VEGF, and I have an example of that as well. So when the pupil is small and the media is a little hazy, one good idea is to go around the posterior border like this. So when you're doing this, you have in effect massaged the baby's the globe, and the pupil dilates as I showed you. The next thing to do is to mark out the ora serrata with a few spots. We do this routinely when we get our fellows to do the laser, but you can do it yourself. Even with a lot of experience, what happens is after some time, the ora serrata becomes obscured, and sometimes you don't want to be over-treating into the pars region. So marking out your anterior most border is a good idea, and then all you need to do is go around 360 degrees and complete it. When you complete it, look back at what you've done and decide, okay, can I go more posterior or can I wait another day, another week? Because many times you don't need to go more posterior and invade the macula. You must be very aggressive nasally, superior and inferiorly, but temporarily you can get away. And I'll show you one more example. So, and then fill in a few days later, a few weeks later sometimes, just with a little, and then they do extremely well. If you have a smooth laser scar like this, they do very well, not just in structural outcome, but also in the amount of myopia. We have now a single-digit percentage of myopia after laser, after we followed this technique. In this rather mid-dilated pupil and a hazy media and the AC looking shallow, you can still complete a laser. And in this one, we did not prefer anti-VEGF because of the already early traction, and we were scared of the crunch. So what we did was, we did the laser thoroughly. You can see that this crescentic area is left behind quite purposefully in the temporal side, but everywhere else, it's a thorough laser. That's important here, that you don't leave out anything in all other quadrants. A week later, you can see that the plus is melted away, and you can only see a bit of the ischemic retina in the temporal and the upper temporal region, and then you can complete that. Now it looks so angry just after that second laser, but they do so well. And this is another 10 days later when they heal very well, and then there's no recurrence after that. A third case, now in this case, you can see that it is really thinned out obliterated vessels, and these are the cases that probably do much better with anti-VEGF. And also you can see here that the ischemia is in the posterior pole. So in this case, we gave anti-VEGF, and one of the questions I was asked is that when would you do a laser after an anti-VEGF? And this is a very difficult question to answer in a one word, but here's the collective experience of a lot of people. So after this baby was given an injection, I'm just following up this baby, and you can look on the top left, that's the timeline. 3 days later, we've repeated the angio, not necessary, but this was many years ago, and we were trying to look at the natural history. A week later, the plus comes down, the blood vessels are growing. 2 weeks later, I'm just going to fast forward a bit now to show you 2 months later, there's a lot of avascularity still. 10 months later, what looks like maybe a nicely vascularized retina, when you do the angio, you see that they still have leaking buds. So this is really the question. Till when would you wait for these, for the vessels to reach the ora serrata? When would you intervene? Would you, of course, if there's a recurrence, then you would intervene much earlier. But if it's just growing naturally, is there a weight cutoff? Is there your comfort zone saying that more than 5 kilos, I'm not comfortable doing under topical anesthesia? What is it? So I think that's a question that we'll be answering in the panel. But here in our center, we use the angiogram to actually delineate where we need to laser up till, especially in these much larger, more difficult to treat babies, and then they do well. Okay, so this is an example. I'm going to move directly to the point that I want to show, where here in this case, a large amount of the temporal retina is spared, where aggressive treatment is done elsewhere. Just to show you that not all babies, you need to come back and fill that temporal area. This eye, for example, all we did was stop here, and week and months later, it had never required any more treatment in that temporal area, and it grew very well. So it's about customization and also the systemic risk factors of these babies and how well it's controlled after laser. But here's an example of a lot of sparing that you can do in the temporal retina, giving a much better refractive outcome as they grow older. Here's a case which had a congenital scar in the macula, which was given anti-VEGF elsewhere. The child was many months after treatment, and when we do the angio, you can see that almost a third of zone 2 anterior onward has the avascular retina. Now, these are the horrendous cases that we all see, the so-called zone half or the posterior zone 1, and here, hemorrhage, disc hemorrhage. These are clearly the cases, indications where you would like to start off with an anti-VEGF and just hope that that is enough. You can see that the hemorrhage does well, the plus comes down, all that ischemia is coming down, but then there's a recurrence. Fortunately, many weeks later, and the recurrence is now in zone 2, and you can take care of that with laser. Posterior laser, these are actually two halves of cropped images, just to show you that if you're faced with a situation where somebody's treated this baby and sends it to you and the ridge is still persisting, what do? Well, before running into wanting to do surgery, you can actually salvage many of these eyes with posterior laser. And this is called secondary posterior laser when you do it after somebody has already done a primary laser. And you'll see that many times, if not most, you will be able to take care of that traction. Of course, another sitting of laser in between that traction may be required after a few more weeks, and then it completely flattens out in many cases. Another example of laser is buying time or indeed avoiding surgery in stage 4A. Here's a ridge that could have been easily taken care of with laser in the right eye, but I want to draw your attention to the left, where this exudation and almost 4A-like picture is going on, and then you do the posterior laser. And then, it really comes down. And sometimes that's the only outcome you need after surgery, and you're getting that just after laser. This is a laser that you've done, and this is quite the example of the other case number 3, where you have to go back and do this supplement laser temporally. But as you can see from this day to about 2 weeks later, the amount of laser that you need to put temporally has come down. So sometimes patiently waiting for this ridge to develop after your first laser will save a lot of extra treatment. So in summary, cover all the avascular regions, plan AP-ROP if you want in stages. And I just want to show you the IROP guidelines. We are still in kind of the pandemic area, and this is available on our website. So you can treat a little earlier than type 1 category, because many times our patients are not able to come back for follow-up in time. And that's what we've put up on the website, and I'm not going to go into the detail. I want to just thank all our contributors, Dr. Subhadra Jalali's team, Dr. Ajay Kapoor, who've been treating through this pandemic and making sure that babies' vision is not lost in this amenably treatable condition. Thank you so much.